Welcome to the ISHLT Joint Infectious Disease and Pharmacy Professional Community Webinar. The 10 ISHLT professional communities are the gathering place for the professional specialties that make up the care teams for our patients. The ISHLT professional community webinars are free and open to all with an interest, and after the webinar, it will be available on YouTube for all. If you are not a member of ISHLT, please consider joining this unique international interdisciplinary society. If you are already a member, thank you for making this organization what it is. If you'd like to join or get more involved in ISHLT, you can contact anyone at the ISHLT headquarters through the website. We hope to see you at the ISHLT 44th annual meeting held in Prague in April 10th through April 13th.
So the ISHLT Infectious Diseases and Pharmacy Professional Communities are pleased to co-sponsor today's webinar titled Transplant Infectious Disease Secrets Shared, Key Insights on Antibiotic Duration, Oral Antibiotic Conversion, and Fungal Diagnostic Selection. My name is Dr. Emily Eichenberger. I am an assistant professor of medicine in the Division of Infectious Diseases at Emory University, and I am joined with my co-moderator, Dr. Amanda Ingemi, a transplant pharmacy specialist at Sentara Healthcare. We are in for a treat today with exciting presentations from 3 excellent speakers. We ask that if you have any questions for our speakers, please enter them into the chat or the Q&A, and then after all 3 presentations, we will open it up to discussion with our presenters. So with that, I would like to introduce our first speaker today, Dr. Nicolas Mueller. Dr. Mueller is professor at the University Hospital of Zurich in Switzerland. He is head of the Transplantation Center at University Hospital in Zurich and senior attending physician in the Division of Infectious Diseases. His expertise is in the care of immunocompromised hosts with infections. Today, Dr. Mueller will be talking to us about the duration of antibiotic therapy for clinical syndromes encountered in thoracic transplant and MCS. Welcome, Dr. Mueller. And just a reminder to unmute.
Here I am. Yeah, thank you, Emily. Thank you, Amanda, for this great invitation. I think it was a challenge to prepare this talk, of course, because as you know, the evidence is what is really missing, and it's quite meager. And usually the experience which we had is that local habits differ quite extensively. What I would like to do in my 15 minutes is really to highlight a recent Delphi panel under the leadership of Shahid Hussain and Mei-Ling Luong, where we discussed key syndromes and tried to explore the level of consensus and potential recommendations. It was really a very humbling and interesting experience. The panel was composed of many different experts of all strata of transplantation, so not just infectious disease people, of course, but also transplant specialists, surgeons, and we really try to come up and see where there is some consensus and where there are still some open questions, and it was actually recently published in Transplant Infectious Diseases. I think the way I would like to go through is to highlight this syndromes which are typical complications after lung and heart transplantation, and where we are always faced with these very difficult questions on what should we give for a therapy and how long should we actually give the therapy. The way I will do that is to highlight the findings of the Delphi panel and also where we did not agree, and then kind of make a reality check after each syndromes, quickly talking to you about how we do it in our center. And I think that's usually something which is of interest. So let's start with the first, which is Pseudomonas aeruginosa pneumonia in lung transplant recipients. Of course, bacterial infections are very common after lung transplantation. Pseudomonas is probably the most important one, is probably the leading pathogen. There are many open questions: appropriate empirical therapy, combination therapy, and in particular duration of treatment, which are all not well defined. So when we discussed that, we discussed about the choice, and we did not really reach consensus that an empirical treatment with a broad spectrum beta-lactam monotherapy should be started. But it was clearly said the local epidemiology should be taken into account. In terms of duration, though, it was a consensus. Over 80% actually said yes, that 14 days would be enough and that 7 days would be too short. If I make in this, for this syndrome, a reality check, in our center, we adhere usually to the 14 days, but I must also say that we do that except very early after transplantation. So in the first 30 to 60 days after transplantation, when we prolong treatment, in some cases when we are not completely sure that the disease really has had a good course so far. The second question which we discussed was anastomotic infection, and this is also a complication which is of course very much feared, and it's actually what we said then. It's that usually in the there is very little guidance, and the coverage, it was not really a consensus, should be according to local resistance situation, usually encompassing gram-positive and gram-negative pathogens, and there should be a high level of suspicion for a fungal etiology. The length per se was not explored, but 7 days were clearly considered too short, while bronchoscopy guided treatment was clearly preferred. When I look at the way we do it in our center, then we usually use bronchoscopy very liberally with sampling, and it's really our main tool to determine etiology and length. If an aspect of fungal etiology is suspected, we would also cover for a fungi. The length usually is not determined by a fixed number of days, but rather by repeated bronchoscopy. The next question which we tackled was the question of Burkholderia cepacia, complex infection in lung transplant recipients. You know that some centers still exclude transplant candidates if colonized with Burkholderia cepacia complex. Usually it's associated with cystic fibrosis. Two aspects were addressed: the initial empirical therapy with susceptibility results still pending, and again here the length of therapy. The initial empirical therapy with susceptibility results pending was a not consensus, but a strong number of panelists said that 3 drugs should be started. There was actually a consensus on this, but some panelists argued even in favor of 4 drugs. Adding an inhaled substance to 3 systemic substances was also considered appropriate. De-escalation to a monotherapy was definitely considered inappropriate. The length of therapy, 2 weeks were considered definitely too short. 4 weeks, okay, if there was a clinical improvement, but no consensus was reached. And if I look again what we do in our center, then we also rely very heavily on bronchoscopy with sampling, which is the main tool also to guide length and type of therapy. We have a very low threshold to prolong therapy if any doubts on a successful outcome persist. The next question which we tackled was Mycobacterium abscessus infection in lung transplant candidate and recipients. It's for many centers a relative contraindication. So we were first interested whether it was okay to list, and the panel actually agreed, yes, it's okay to list, but there must be some conditions fulfilled. So 50% of the panelists thought that the negative acid-fast bacillus staining should be achieved at least, and 50% say it's not necessary or even not possible. You see here, it was really a 50-50 decision. The condition of a negative culture was clear that, of course, it would be nice to have, but it was not a prerequisite because it was in many cases not realistic to get. Ideally, initiation of treatment before transplantation should be done. The waiting list time is a big issue because in some countries and in some places, waiting time are very long, so we have no clear idea when to start. Treatment for colonization infection after transplantation was not assessed. Again, if I look at the reality here, we try to eradicate and prefer an intensive therapy at least 3 drugs. Often, due to waiting time, we cannot treat until transplantation. So just up to the point of transplantation or the time to start therapy accordingly, because our waiting time is too long. Once we have said, usually we would commit to a transplantation, even if the result is not achieved at time of transplantation. So there is no clear length here. In a way, of course, if you achieve clearance before then, you might stop before transplantation, but many would treat up to transplantation and continue treatment afterwards, and then guide the length of treatment by bronchoscopy. The next question which we tackled is invasive aspergillosis in lung transplant recipients. There was a consensus that the monotherapy would be okay, but not on duration or endpoints. 12 weeks were considered appropriate if a clinical improvement, that was 72% of the panel agreed on that, and or it was not mutually exclusive, radiological improvement should also be a prerequisite. So some said clinical improvement alone is fine, others said it must necessarily have an improvement of the radiologic findings to really stop therapy. Consensus was then that 12-week was a minimal duration plus consideration of additional elements, so the clinical course, microbiological test, and radiological improvement all together. There was a discordant findings in the question whether galactomannan and or fungal cultures with no radiologic findings should be treated. Is there a role for preemptive therapy? So there was a consensus that if ABL is positive for Aspergillus, but negative for galactomannan, and there are no radiological findings, you should not treat, but it was also not a consensus, because the limit was 80%, that with a negative BAL in fungal culture but a positive BAL galactomannan should be treated. Is an observation possible or not? I think every center does it a bit differently. So many cases, unfortunately, of course, are not so black and white. In case of persistent radiologic changes, scarring, we often use a PET-CT to guide length of treatment. In case of unclear weight of a microbiological finding, we often err on the side of starting treatment, waiting for the next surveillance bronchoscopy. Again, here, I think it's really very difficult to just give a single number, but in the end, together maybe with a PET-CT, which really shows resolution, even if you see something in a CT scan, you might stop treatment. Of course, there are other prerequisites which need to be fulfilled, as a good clinical course and so on, as I mentioned before. Coming to the next question, which often is a big discussion, is respiratory syncytial virus infection in lung transplant recipients. It's quite common, but many aspects of treatment are unclear. Should the treatment be given at all? And if yes, how long? So there was a consensus that infection with a declining lung function should be treated in any case. We did not discuss the type of therapy because it was really more on the length and stewardship. There was no consensus really on duration and or endpoint. You see that duration was all over the place. There was a majority saying 7 days. Excuse me. There was no common ground. So there is no fixed duration, but clinical improvement must be a main endpoint. How do we do it in our center? We have a mix of clinical course and virological findings. So we also adhere a little bit to the CT values, having learned that also from the SARS-CoV-2 to determine length of treatment. But in the individual patients, it's really sometimes very difficult to clearly say when you should stop. But if we see that we have a good clinical course and CT values really are increasing steadily, then we would stop treatment and rather not just treat a certain number of days and then stop without looking at these additional points here to determine the length of treatment. And coming to one of my last is the LVAD infection prior to and after heart transplantation. This is really a great challenge, even with the existing guidelines. Empirical treatment with MRSI included was depending on the geography of the panelists. So how much MRSI do you see? Beta-lactam therapy with good gram-positive coverage was preferred in places where no MRSI needs to be covered. Anti-pseudomonal or antifungal agent alone was considered an under treatment. And again, the duration, there was no consensus for optimal duration. 6 to 8 weeks was considered effective but unnecessary. This is quite difficult. 2 to 4 weeks was deemed appropriate by 55% of panel members. Again, duration per se is probably not appropriate, but additional endpoints necessary for evaluations need to be taken into consideration, as we always do. So clinical and microbiological findings. Is a suppressive therapy maybe something to think about after initial episode was deemed effective but unnecessary? So most of the centers, at least who participated in the Delphi panel, would not do it. Following LVAD explantation and heart transplantation, antimicrobial continuation for 2 weeks was considered appropriate after transplantation, and there was a consensus. Again, the reality check, it's very much case-based, which is usually an acronym for it's a daily discussion with the ICU, transplant physicians, surgeons. If you go into transplantation, usually you can prolong treatment for 2 weeks or so and then usually stop because the foreign material is removed. But before, it's really very difficult to clearly say a finite numbers. I think it's always a mix of different factors which then will guide your decision to stop treatment. Thank you for your attention.
Thank you very much, Dr. Mueller. For your excellent presentation. Again, please place any questions in the chat and we will address them after the talks. It is now my pleasure to introduce Tara Fallah, transplant pharmacy specialist from Ohio State University Wexner Medical Center in the United States. She is a board certified transplant pharmacist practicing in lung transplantation. Dr. Fallah will be speaking to us about opportunities for IV to PO conversion in thoracic transplant and MCS.
Oh, you just need to unmute.
The ideal route of administration of any medication is the one that achieves serum concentrations sufficient to produce the desired effect without producing unwanted side effects. Most often, the safest, most inexpensive, and most convenient route of medication administration is oral administration. There is also this advent of new oral antibiotics that achieve potent broad-spectrum activity that is really broadening our ability to switch patients over to oral therapy more quickly. Now, when we're thinking about switching a patient over to oral therapy, there's a few things we want to consider. One is that it tends to be easier to administer. You don't need any expertise to give PO medications. The oral equivalents tend to be less expensive than their IV counterparts. We also see a decrease in adverse effects of IV formulations, such as not having to worry about toxic vehicles. And then we can also see a decreased risk of line-associated complications. This may be a line-associated infection, extravasation, or thrombophlebitis. Also, because we don't need to have any special administration techniques, it allows patients to receive therapy outside of the hospital, and so we have an overall shorter length of stay. However, there are some downsides to consider with oral therapy. One is that the patient has to have enteral access, whether the ability to swallow medications or some other enteral access. We also have to consider the potential for lower bioavailability or slower onset of action, depending on which agent that we choose to use. Now, there are 3 types of IV to PO conversion that we would think about. The first is sequential therapy, where you're replacing the IV version of a medication with an oral counterpart of the same compound. If you're using a high bioavailability PO compound, then you can effectively switch these patients over at any point in therapy, although we generally do want to wait until clinical stability or defervescence. The next option is switch therapy, where we're converting an IV medication to an oral equivalent where the drugs are within the same class and have the same level of potency, but are different compounds. An example of where you might see this is if you're using an IV medication that doesn't have an exact oral equivalent. However, you do want to make sure that if you're using another agent, that you're still having the same spectrum of activity and that you're still achieving appropriate serum concentrations. The serum concentrations don't need to be the same as the IV formulation, but they do need to be high enough to hit the MIC needed for that microbe. The last one that we think about is step-down therapy. And this is where you're converting from an IV medication to an oral agent in another class or to a different medication within the same class, but the dose, frequency, or spectrum may not be the same. This may be an example of starting off with broad-spectrum IV antibiotics and then narrowing to a more targeted oral therapy. Now, 4 scenarios to think about when you're going from IV to PO. The first is when you're using the same drug that has the same AUC in both IV to PO. So fluoroquinolones would be a good example of this. Theoretically, given how bioavailable the oral version is, you could effectively switch them at any point, as I previously mentioned. But again, also, you want to make sure that the patient is clinically stable before you do so. The other option would be you use the same drug that has a much lower AUC in the PO formulation than it does in the IV. This is a less desirable area, although depending on the site of infection and the microbe that you're treating, it may still be a feasible option. The third scenario is where you're using a different drug and then the oral version has good bioavailability, but they're not the same. This may be a situation in which, if the oral agent has a lower bioavailability, you may switch to an oral agent that has better bioavailability. So an example here, ceftazidime and Cipro may be used to cover quite a few of the same microbes. However, ceftazidime doesn't have an oral equivalent, so you switch over to Cipro instead. Or we can see that amoxicillin clavulanate, the oral equivalent would be ampicillin sulbactam, that has lower bioavailability, so you can consider levofloxacin and metronidazole, which has a similar spectrum of activity, and it's much better bioavailability. The fourth scenario is where you're going to a different drug and poor bioavailability. This is arguably the least desirable option, although depending on what you're trying to cover and what the spectrum of activity is in the site of infection, this may still be an appropriate option for some patients. Now, specifically looking at the medical management of patients with MCS, the guidelines from the 2017 ISHLT guidelines on this do actually have decent ways to look at how to think about this in terms of when to use IV to PO. If you're treating a superficial pocket or a superficial driveline infection, the guidelines state that you can treat with either IV or oral antibiotics for a minimum of 2 weeks until the infection is resolved, although this is only appropriate to start with PO if the patient doesn't demonstrate any sepsis or systemic infection. What we more often see is that you start with broad IV antibiotics targeting MRSA and Pseudomonas until you have a target pathogen, and then you can switch over to PO. If it's a deep pocket or driveline infection, we want to start with IV antibiotics and generally stay on IV until clinical stabilization, usually 6 to 8 weeks, depending on the guidance from our ID colleagues. And then once the patient has achieved clinical stabilization, we can go to long-term oral suppression therapy. If it's an MCS pump or cannula infection, then we really want to start with IV empiric antibiotics and then followed by targeted therapy. If they're a bridge to transplant, we would continue the antibiotics until transplant. In many of these patients, we would continue IV antibiotics until time of transplant, depending on the severity of the infection. If these patients are destination therapy, then we start with IV antibiotics, again, usually a course of 6 to 8 weeks, depending on what the recommendation is from infectious disease. And this can be followed by long-term oral antibiotic suppression once the patient has defervesced. Now, for patients with persistent bacteremia, relapsing infection, septic emboli, sepsis despite adequate therapy, we generally want to keep these patients on longer-term IV antibiotics. And then eventually, if they are a destination therapy, we can consider them for oral antibiotic suppression once the infection has been adequately managed. Everything that I just discussed in that table is also well summarized in this flow sheet, but the main differentiating point that I want to draw your attention to is systemic symptoms. If the patient is displaying symptoms of critical illness or sepsis, then they're really not a great candidate to start off with oral antibiotics, and so we want to start with broad spectrum IV, and then once they're stabilized, you can consider going down to oral antibiotics. Now, looking at heart and lung transplant patients, We know that there's a wide variety of pathogens that cause infection in lung transplants, and many of these are nosocomial pathogens and can be multi-drug resistant pathogens as well. Pneumonia is the most common type of infection seen in lung transplant recipients, especially within the first year, although you can also see deep surgical site infections, empyema, wound infections, mediastinitis, sternal osteomyelitis, and pericarditis. Of all these patients that develop early onset pneumonia, the most isolated organism that we see is Pseudomonas. Now, even in later onset pneumonia outside of the first year after transplant, these patients see quite a bit of hospitalization and healthcare institution exposure, so you may still see more MDR or nosocomial infections even after they're ways away from transplant. The donor-derived bacterial infections that we're treating our lung transplant recipients for could also include nosocomial and MDR pathogens. And so what we're finding is that the spectrum of activity of our antibiotics may be most limiting for when these patients can switch from IV to PO. For heart transplant recipients, there was a study done in 2001 in Stanford University where they assessed 620 heart transplant recipients, and they still found that pulmonary infections were the most common, followed by urinary tract infections, blood infections, and mediastinal infections. They also found Pseudomonas and Staph to be some of the most commonly cultured bacteria in these patients. So again, this is why we consistently broadly cover for Pseudomonas and Staph when we're starting empiric IV antibiotics. Since I keep discussing Pseudomonas and Staph, I wanted to narrow in on these two bugs. Pseudomonas is intrinsically resistant to several antibiotics, and this is due to low permeability of its outer membrane. It's also very good at quickly developing resistance mechanism through loss of porins, overworking of the efflux pumps. And so you can see an increasing prevalence of MDR Pseudomonas. Now, for patients who do have quinolone sensitivity, fluoroquinolones are the only oral treatment option available for these patients. And as looking back at what I previously stated about how sensitivity is being limiting, if patients lose sensitivities to fluoroquinolones, then there are no oral options to treat Pseudomonas. The good thing about fluoroquinolones is they're rapidly, almost completely absorbed from the GI tract, and so they have high oral bioavailability and a large volume of distribution. This large volume of distribution means that it concentrates in tissues and levels that often exceed serum drug concentrations, especially in certain tissues that we may be more interested in, such as pulmonary tissue. It could also be genital tract tissue. So these are areas that fluoroquinolones are really effective. Also, some of our fourth generation fluoroquinolones, specifically tovafloxacin, does penetrate non-inflamed meninges. So we may see an advent and an increased studies looking at the use of fluoroquinolones and other types of infections too. The next bug that I wanted to discuss is methicillin-resistant Staphylococcus aureus. Now, we know that Staph aureus can develop this resistance based on the staphylococcal cassette chromosome, or SCC typing. The reason this is important is this type of resistance pattern really helps us determine whether the Staph aureus is a community-acquired MRSA versus a hospital-acquired MRSA. If it is a community-acquired MRSA, we have a little bit more flexibility with our oral antibiotics. We can use trimethoprim as part of sulfamethoxazole trimethoprim. We can use clindamycin or tetracyclines. These are most commonly seen in skin and soft tissue infections. However, because our patients are typically so critically ill and because they often have nosocomial infections and repeated hospital exposures, more often than not, we are treating our patients for hospital-acquired MRSA. In empiric coverage of hospital-acquired MRSA, you're really looking to use our glycopeptides such as vancomycin as initial empiric therapy. For hospital-acquired MRSA, the main oral agent that we would consider using is linezolid. Now, similar to fluoroquinolones, one of the good benefits of linezolid is that it is a highly bioavailable agent. And so again, you're going to see pretty good levels of PO serum concentrations compared to IV concentrations. I spent quite a bit of time talking about all the patient populations that we would want to try to switch over to oral therapy. However, it is not a good option for everyone. First and foremost, you want to make sure that the patient has enteral access, whether they're able to swallow medications or if they have an NG tube, an OG tube, GJ tube, something that allows them to get enteral medications. If you have a patient that presents with intractable nausea or vomiting, then they also would probably not be a good candidate for oral, or if they have absorption concerns. For an example, if they've had complicated bariatric surgery, if they have severe gastroparesis, or if they have severe gut edema as well. In patients that are septic or very critically ill, we would ideally want to start them on IV antibiotics and then not necessarily consider switching them over to oral until we achieve some level of clinical stabilization. We also want to consider drug properties. We know that several of our oral agents can be bound by minerals such as calcium, magnesium, iron, or if we're using any type of binding agent. And so if you're not able to appropriately space those out, then the patient may be better left on IV. And then lastly, not all of our therapies have oral equivalencies. This is especially true as you start going into the more resistant bugs that don't have oral therapies that are available for coverage. Overall, we know that the safest, most inexpensive, and most convenient route of medication administration is oftentimes oral. When treating MCS and transplant patients, we want to consider site of infection, severity of illness, and drug properties to determine when it's appropriate to make this conversion. And you want to avoid oral therapy in patients that are critically ill, unable to tolerate oral therapy, or do not have oral therapies that provide adequate coverage.
Thank you so much, Dr. Fallah. So it is now my pleasure to introduce Dr. Nancy Law, who is an Associate Clinical Professor of Medicine in Transplant Infectious Diseases at the University of California, San Diego. Dr. Law is the Assistant Director of the Epidemiology and Antimicrobial Stewardship Program at UCSD and has a particular emphasis on the epidemiology and stewardship in immunocompromised hosts. She is also an Associate Program Director of the UCSD ID Fellowship Training Program. Dr. Law will be speaking to us on fungal diagnostic stewardship in thoracic, transplant, and MCS. Dr. Law, we are thrilled to have you join us.
Oops. Hi, everyone. Thank you for having me. So I'm just going to jump right in. So this first slide is just showing really the burden of invasive fungal infections and kind of our current diagnostic tools that we have available. So candidiasis, aspergillus, and mucor all have a huge burden on our healthcare system. There have been reported greater than 400,000 cases of candidiasis, greater than 200,000 for aspergillus, and mucor about 11,000 per year. The mortality rates for all of these different diseases can range from anywhere between 10% to 90% in the literature. And the clinical presentations or the symptoms that these patients have range from anywhere from abdominal to a variety of CNS infections, pulmonary infections. So it's really a variety and all over their bodies. The risk factors that have been studied throughout literature too are also very wide and, can range from length of stay from the time they are in the intensive care unit to their underlying diseases such as COPD or lung disease, heme malignancies, and then just being an immunocompromised patient. The current diagnostic tools that we have available are listed below, and we'll go into a little deeper discussion about those. So specifically for our thoracic transplant and MCS patients, there has been different quotes throughout medical literature. In our lung transplants, they say up to about 8.6 patients can develop IFIs during their first year after transplantation. And a lot of this is the variability is because of the different types of institutional measures that people use. So antifungal prophylaxis, the type of prophylaxis they use versus immunosuppression, and the way that they're doing their prophylaxis too. For our heart transplant patient, the estimated risk of 1 year IFI in heart transplant is about 1 to 14%. And then for our VAD patients or MCS patients, fungi are not usually a common cause of driveline infections, but when this does happen, you really have to worry about deeper tissue infections, such as the VAD pocket or in the bloodstream. And right now, the most common one that we see is Candida albicans, followed by glabrata, then Krusei, and then parapsilosis. These are really associated with extremely poor outcomes in that population. This is just showing a geographic picture of the different types of fungus that we can see throughout our different area in the United States. And so depending on where you are, you're going to look at your different testing for these. So the current state right now and why diagnostic stewardship is really so important is because we really have limited antifungals available. And a lot of them are in the same class or they have very similar side effects. And so when you kind of knock out one, you knock out a few that you can't use. The current diagnostic state relies on early acute your patients like outcomes rely on early acute diagnosis of IFIs and really seeing the identification of the causative fungal pathogen that it is. IFIs have been associated with a really high morbidity, mortality, and economic burden on the healthcare system currently. It was quoted in 2017 that it was costing the healthcare system about $7.2 billion for that. Currently, the gold standard for diagnosing IFIs is really microbiology and histopath. However, this is low sensitivity and there's a long turnaround time, which causes a delay in appropriate therapy and prolonged empiric treatment. So currently, kind of on the antifungal treatment strategies, different things that we use to try to help us in the management is the first one's really low specificity. So it's the antifungal prophylaxis kind of strategy that we use. So this is where you look at the risk factors, prediction scores, and then, colonization in your patient. Preemptive is any of these non-culture based testing, if they're positive, but have tons of limitations, which we'll go into. This is really intermediate specificity, and the targeted therapy is when you have the histopath or at least the microbiological data to really guide you in your specific treatments. This is just showing the tons of prediction score studies that have been done for IPA and candidiasis. So you can see, these are looking at kind of depicts all the different ways that they have found the different risks associated with invasive fungal infections, and then the positive and negative predictive value in each study listed here. And a lot of these studies were done in our ICU patients, but not specifically in our thoracic transplants or MCS patients. So let's dive into the diagnostic tools that we currently have. So these are non-culture-based studies currently available. So the first one we'll talk about is the Fungitel. So this one is it basically looks at the beta glucan in the cell walls of most fungus, and this is except mucor and crypto. I'm not going to state out specifically the sensitivities or specificities as you guys can see them here, but really concentrate on the limitations here. So there's no speciation that comes with this type of testing. There have been seen to be lots of false positive, especially in bacteremic patients, critically ill patients, as well as lung transplant patients. Our serum galactomannan has really reduced sensitivity in non-neutropenic patients, and it's not the best one to be used in patients with normal white counts or ANCs. So, and there has been confounding factors that have been found, and one of them is thought to be different types of antibiotics. However, most of this has been manufactured out, and it's thought to be less of a confounder currently. The lateral flow device is a rapid single sample point of care test that detects Aspergillus extracellular glycoprotein antigens. It's not widely used, and the sensitivity tends to be decreased with the use of antifungals currently. So for blood cultures, these are the samples really, your sensitivity really depends on the sample that you get. The samples are grown in your microbiome lab. However, they can take up to 4 to 8 weeks to finalize, and that causes a huge delay. For the galactomannan in your BALs, this is a more useful test. However, there's different, people use different cutoffs for it. And so it's very useful in our lung transplant patients, and in positive in a liver transplant patient has a high predictive value for invasive aspergillosis. However, in people in histo areas, it can be positive in 50% of histo cases. So in these patients at risk for other fungal infections, it's important to keep that in mind. So specifically for invasive candidiasis, there's been a variety of tests out there that have been developed. So the mannan/anti-mannan antibody combo, as well as the germ tube antibody, is an indirect immunofluorescence assay that is against a protein expressed during tissue invasion and also biofilm formation. The sensitivity seems to be diminished in immunosuppressed hosts, and there needs to be a certain amount of time needed to mount the response. It doesn't distinguish between acute versus past infections, and the germ tube really has a low sensitivity for Candida tropicalis. PCRs are developed, however, there's high cost and it's labor intensive. There's actually none approved currently by the FDA, and it's not been standardized or validated in multi-center trials. The T2MR is a detection of a specific molecules used in MR. And so this is seen to detect Candida albicans, Tropicalis, Glabrata, Krusei, and Parapsilosis. However, in the direct study where the test came out of, there was a discrepancy in invalid test or discrepant test in about 7 to 9% of the patients there. And so it's really, there's a lot of unknowns with this testing, such as, antifungal use on the assay performance, as well as the kinetics and the prognostic values for it. So this is a table showing kind of the positive predictive value, negative predictive value. And the negative predictive value in a lot of these non-culture-based testings are pretty good. So they're good at kind of ruling out infections, but not so much at ruling in infections. And so it's just something to keep in mind whenever you are diagnosing. So I want to dive into specifically endemic fungi that we see throughout our areas. So Cryptococcus and all of these endemic fungi, the gold standard is going to be culture and direct visualization of the organism. So again, however, that is delayed time to positivity, and it's not always possible. So in Cryptococcus, the antigen testings available are listed here. However, in these types of testing, there can be false positives, especially with RF and other infections. For antigen, we usually rely on the antigen testing for meningitis or CNS disease. And that's why it's really proposed that all patients who are, if they have any neurological findings or a high serum titer, but they're immunocompetent, to still evaluate for CSF disease. And then all immunocompromised hosts should definitely be evaluated for CNS disease. For the people in the histo area, we do use the antigen testing too as well. However, the serum and urine sensitivity around is about 80% in this disseminated disease. The urine antigen is better than the serum antigen in testing. And there is high BAL sensitivity. The problem with this test too is that there's a lot of cross-reactivity with other endemic fungi. So it's something to consider when you're using this. For isolated pulmonary disease, multiple different techniques should be used in the diagnosis. And then antigen testing is the most helpful in disseminated disease. For people in the blasto area, again, this is another test for the antigen testing where we do see high sensitivity for urine, but there's significant cross-reactivity. So low sensitivity for serum and BAL. So something to just always keep in mind when you're trying to figure that out. Cultures really have a high sensitivity and are very useful in the diagnosis. The antibody testing is useful in the setting of subacute infections and especially ones that are pulmonary nodules. For cocci is one that we always see in our area here. We use the antigen testing. It has modest sensitivity and high cross-reactivity. The IgM has tons of false positives. There's been quotes between anywhere between 50% to 82% of IgMs can be false positives. The IgG can often resolve after infection and doesn't also remain detectable for life. So a lot of this area, we rely on, risk assessment too as well. Usually they'll do a screening test, and then the comp fix will be kind of your confirmatory testing here. So the IDSA back in 2016 recognized that a lot of centers do not also have these non-culture-based testing. So it was, put out a statement that it was really important that we still use pathology as well as a cultural to really diagnose these infections. And then also just kind of reiterating this for invasive candidiasis, cultures of blood and other samples collected under sterile condition were really the way to the gold standard to diagnose invasive candidiasis. They did, mention that there are a lot of these these new tests out there, but they really recommend using them in adjunct with your other clinical judgment, as well as other testing that's being done. They also recommend that anyone that you have concern for invasive aspergillosis to get imaging to support your diagnosis, as well as they do recommend highly a bronchoscopy in these patients. So the European Confederation of Medical Mycology, as well as the mycosis study group too, kind of for Mucor, developed this algorithm to specifically help with diagnosis. So it is, again, reliant on imaging as well as sampling and other non-diagnostic tests for the diagnosis of this. So the ultimate goal or the ideal diagnostic test would be the dream that everyone has is a minimally invasive, have a high rapid turnover time, very sensitive and specific test, and is able to differentiate between colonization and invasive disease. The other thing that we always wish for is speciation and susceptibility data. There is not currently a test available. However, there is hope on the horizon as there are many clinical trials looking to evaluate diagnostic methods for diagnosis of fungal diseases that I have listed here. And that's it. Thank you.
All right, thank you, Dr. Law. We'd like to open the session up for questions to our panelists. It looks like there was a question in the chat. Let me pull that up. First question in the chat is for Dr. Mueller, and he already answered, but I'll let him kind of verbalize his answer here for everybody. Are there published data on PET for determining the end of therapy in lung transplant?
For invasive aspergillosis, you mean? Yeah, only comparative studies. We really lack, very good and strong, reliable studies here. But I think, there has been this paper out by Monica Slavin where they really looked at the FDG PET and compared it to the CT scan. And in those patients, I think there were about 18 patients where they did a follow-up in both CT scan and FDG PET. And in 61, there was a discrepancy, meaning that the FDG PET actually did not show any activity anymore, while you still saw some radiological findings. And I think that was reason enough then, because these patients had been treated for a long time, to actually stop treatment. I think in our experience, for some cases, it really might be helpful. I think it should be done on a case-to-case basis. There is not enough evidence to, recommend that on a larger scale. But we all have those patients where we still have some radiological findings, even after 12 weeks, maybe even after, a longer prolonged time, maybe 16 weeks of therapy. And then to kind of judge on the activity, the FDG PET might be a reasonable choice in those specific patients.
Thank you. Those were all such fantastic talks. Please be sure to put your questions in the chat. I actually have one for Dr. Fallah. Just one of the things that frequently comes up in the clinical setting is switching from an IV cephalosporin to an oral cephalosporin, whether it be kind of for completing treatment for a bloodstream infection or a pneumonia, that sort of thing. I mean, is there data there to kind of support that practice or to not support that practice?
Yeah, thanks for the question. So when you're thinking about going from IV to oral cephalosporins, it kind of depends on what the transition is, because cephalosporins can be a little bit more limited in terms of IV to PO conversion, in terms of a lot of them don't have direct PO conversions. So you're oftentimes switching to a different agent, either the same generation or different generations. So it may be a little bit easier when you can stay within the same generation. For an example, going from IV, cefazolin to PO Keflex is generally a more seamless transition because you have similar bioavailability. Keflex is decent bioavailability. You're going to see a similar spectrum of activity. This can be a little bit more difficult, for an example, for ceftriaxone, because you don't really have a great alternative for a third generation cephalosporin. And so you could look at other options. For an example, you could look at some of your third generation PO cephalosporins. However, what you really would look for is specifically site of infection. So making sure that what you switch to has good penetration at that site of infection. And then you just want to make sure that it's a similar MIC that you would achieve to cover that infection. I think given the complexity of IV to PO conversion with cephalosporins, that's a little bit more difficult. And then if you are using something like cefepime, then you're typically looking for pseudomonal coverage. And as we had talked about, that can be pretty limiting. And then if you're looking at like ceftaroline, then you're looking at hospital-acquired MRSA treatment, which can also be pretty limiting. But I would argue that as a class, cephalosporin transitions from IV to PO is one of the more complicated ones because you don't have those immediate IV to PO conversions.
Thank you for that, Dr. Fallah. The next question comes for Dr. Law. For a transplant patient who is admitted with pneumonia, what are your thoughts on the need for fungal testing at the time of admission?
I think this is a great question, and this brings me back to medical school, where I rely a lot on my history taking and just clinical risk assessment. So, I think a big thing is, has this person had recurrent pneumonias, and are they kind of failing antibiotics? And so it makes you want to look at other causes such as fungal infections. I, highly recommend getting the CT scan, and then I am best friends with our radiologist here, and I will actually go down and read if there's any concern or anything that possibly looks like it. I do recommend that. And then I will, if that is like even a little bit concerning, I will do the fungal testing. And a lot of it is assessing the patient's history, like, are they gardening, do a lot of landscaping, a lot of construction. Here in San Diego, we have tons of construction going on all the time. So I think a lot of that just relies on your history and your radiographic imaging too.
Great. I don't want to dominate all the questions, but I also have one for Dr. Law. And I think this is pretty tricky, at least from my review of the literature, but I was wondering if there's any utility in kind of following any of these non-invasive diagnostics over time as a response to treatment. I really can't, I always kind of struggle with this in the clinical setting. And I didn't know if you had any words of wisdom on that, or if it's kind of a data-free zone.
Yeah, it's a little bit of a data-free zone. And I think a lot of these non-culture-based tests are coming out now. And so there's very limited data on it. None of them specifically mentioned in the literature how they can be used for kind of, evaluation of treatment response. In that, I think some of us will use like the beta-D-glucan, kind of trying to see if it's, possible, but there's really no data in that area at all. And there's actually, the crypto, when people are being treated with it, a lot of times people say, don't even check it. So there's actually data saying not to do it on some testing.
That comes up for us too. We actually just had a large discussion about a crypto patient and whether we should continue checking, and we decided not to. I had a question for Dr. Fallah, actually. You mentioned absorption concerns for, limiting your IV to PO conversions. How do you determine if the patient's having absorption concerns? You kind of mentioned a couple of, disease states where you might be concerned. Does that mean that they can never go to PO? And is there anything else that you're looking for regarding absorption?
Yeah, that's a great question. I think one thing that's really helpful for us is that a lot of our patients in transplant are on TAC. And so I found that's actually a very helpful surrogate in terms of determining how well a patient's absorbing certain medications. And that doesn't necessarily help with the MCS patients, but we all know the number of variables that can affect TAC absorption. There are certain patient populations that I kind of know at baseline may have a little bit more difficulty with absorption. So for an example, CF is the patient population, or if there's certain medication, like, for lung transplant, the enteral access for these patients is really variable. So when we're looking at certain medications that we know are absorbed better on an empty stomach versus food, so going to antifungals, it's really hard to get a patient who's NPO to get any meaningful level of posaconazole. So that might be a patient who would not be a great candidate for oral posaconazole, or you may have to find more creative ways to get better absorption. We have patients that present with profound gastroparesis, and so those may be patients that we have a little bit more concern on whether they can absorb medications. The extent to which this is limiting in terms of switching a patient from IV to PO is probably dependent on the clinical scenario. where there may be some level of absorption concerns, but is it enough to negate the ability to switch that patient to PO? Other things that I think about if a patient is profoundly fluid overloaded and we're worried that they're, if they have significant gut edema, which was another one that I had mentioned. And then thinking about other patient populations that have come up in the past. I've had patients with Roux-en-Y, like she just recently had a Roux-en-Y J place. And so this was a patient whose TAC levels were reflective of this. And so we had significant concerns. So I think overall, to summarize which patients I would think about, there's certain patient populations. I think they most commonly manifest in lung transplant, but you could really see this in any patient population, that we know that there's certain patient characteristics. And then you also want to look at drug properties too. If there's certain medications that you need a specific absorption scenario in order to know that they'll achieve appropriate serum concentrations.
Great, thank you very much. I'm not seeing anything else come into the chat. So we may end about 5 minutes early and give everyone about 5 minutes back of their afternoon. So thank you so much to our panelists, and these were really excellent talks. And if you want to view it again, you can go to the YouTube channel, tell your friends, tell your colleagues. We'll all think the link will be on the ISHLT website. So thank you so much to everyone.
Yes, wonderful talks. Thanks to our speakers, Dr. Mueller, Dr. Fallah, and Dr. Law for their excellent talks. Hope to see you in Prague.